I'm going to talk about vasoactive drugs used in neonates today. And it's a vast topic, but I'll try to cover it as much as possible in this short time. Uh, so before we go any, sorry, I'm not able to, yeah, okay. So before we go any further, let's see what are the indications where we'll use this vasoactive drugs. So the most common is the hypotension or shock. And the definition, as we all know, in neonates remains controversial. Low blood pressure, however, is not a mandatory criteria for initiating treatment. Blood pressure may be maintained and the compensated with a shock. So, if there are any clinical or biochemical signs of hypoperfusion, the neonate may be still treated. The main goal of starting the vasoactive drug is to restore cardiovascular status and to normalize the end organ perfusion. And if there is a point of care to be echo available, it can be used along with the clinical and biochemical features of hyperperfusion to help us guide what vasoactive drug to be used. We'll see that at the end of the slide. So, NNFI in their 2023 guideline defines hypotension or shock as mean blood pressure, which is less than the gestation age in a less than 32-week preterm who is more than 72 hours of age, or mean blood pressure less than gestation age in neonates of any age between 32 to 36 weeks. And in gestation age who are more than 37 weeks, it's advisable to use the nomograms for systolic and diastolic blood pressure, which is less than the fifth centile. And there should be presence of any one of the following clinical or biochemical abnormality, which is suggestive of poor perfusion. Capillary refill time more than 3 seconds, urine output less than 1, lactate more than 3, base deficit more than 8, and in term neonates, a difference of more than 3 degrees Celsius in the core and peripheral body temperature. And in preterm neonates who are less than 32 weeks and between first 72 hours of life, in the first 24 hours of life, NNFI defines severe hypertension as mean blood pressure, a value of less than 5 for the corresponding gestation, and that can be treated. And in 24 to 72 hours of life, hypertension without any clinical and biochemical signs of poor perfusion may be treated if the mean blood pressure remains less than the gestation age in weeks. So before we go any further, let's just revise the basic physiology of the blood pressure, because we are going to use all these terms also, and all the vasoactive drugs which we are going to talk about will affect one of these parameters. So the figure on the left hand side, if you see, the preload, contractility, and the afterload decides the stroke volume. Heart rate into stroke volume decides the cardiac output, and the cardiac output with systemic vascular resistance decide what the blood pressure is. On the right hand side, if you see, is the effect of the heart rate on the cardiac output. So both excessive tachycardia and significant bradycardia actually worsens the cardiac output. It's only the mild tachycardia which improves the cardiac output. Vasoactive drugs. So these are pharmaceutical agents that affect the blood pressure and heart rate by vasodilatation or vasoconstriction. They act through various receptors and non-receptor mediated effects which are present in heart and peripheral vascular. They help the body's homeostatic mechanism to keep hemodynamic under control. This table on the right hand side shows us what are the common receptors which we are going to talk about. The adrenergic receptors are alpha-1 adrenergic receptors, which are present on cardiomyocytes and vascular smooth muscles, and which increases the cardiac contractility and vascular resistance. Alpha-2 are present in presynaptic neurons, which reduces the vascular resistance. Beta-1 and beta-2. Beta-1 is present in cardiomyocytes and increases the cardiac contractility and heart rate, and beta-2 causes reduced vascular resistance. Dopaminergic A1 is present in splanchnic blood vessels and causes splanchnic vasodilatation and increased blood flow. And dopaminergic A2 is present in central nervous system. Vasopressin receptors V1 and V2. V1 increases the vascular resistance, while V2 decreases the vascular resistance. So how to classify vasoactive drugs? So they can be classified as what we generally know as inotropes, which increases the cardiac contractions. Examples are dopamine, dobutamine, milrinone, adrenaline. Chronotropes, which increases the heart rate. Dopamine, adrenaline, dobutamine at higher dose. Vasopressors, which increases the vascular tone and increases the systemic and pulmonary vascular resistance. The examples are adrenaline, noradrenaline, vasopressin, and dopamine at higher dose. Vasodilators, which decreases the arterial plus venous tone, and which we are going to talk about is milrinone here. Inodilators, which are the ones which increases the cardiac contractions while decreasing the systemic and pulmonary vascular resistance. Milrinone and dobutamine are the examples, and eusinotrops are the drugs which causes diastolic relaxation of the ventricles, and the example is milrinone. So let's go to individual drugs. Dopamine, it's an endogenous catecholamine. It acts via 4 receptors, D1, D2, adrenergic alpha 1 and beta 1 receptors at different doses. So at low doses of 0.5 to 3 microgram per kg per minute, it produces vasodilatation in the renal, mesenteric, and coronary vascular beds through the dopaminergic receptors. At doses 3 to 10 microgram per kg per minute, it has a alpha 1 vasopressive and beta 1 inotropic effect, and it effectively increases systemic blood pressure and cerebral blood flow in hypotensive neonates. And at doses more than 10, it has an unpredictable effect on the pulmonary vascular resistance and actually can aggravate the hypoxia through right to left shunting across the PDA in infants with pulmonary hypertension. Actually, it can worsen the PPHN. Adverse effects are transient reduction of TSH, prolactin, and growth hormone levels, and excessive peripheral vasoconstriction with subsequent decrease in the cardiac output at higher doses. Dobutamine is a synthetic catecholamine. It is a beta adrenergic agonist with strong beta 1 activity and a weak beta 2 and alpha 1 activity. It increases the cardiac contractility, heart rate, and cardiac output and produces moderate vasodilatation. It acts on peripheral vasculature through vascular alpha 1 and beta 2 receptors. At doses less than 5 microgram per kg per minute, it increases the cardiac output and lowers the afterload by exerting vasodilator action on peripheral vessels. At doses more than 5 microgram per kg per minute, it can cause vasoconstriction via its agonistic action on alpha 1 receptors. And at doses more than 10, it can worsen the tachycardia in patients without any additional cardiac output increase. Tachycardia, increased contractility can potentially actually worsen the myocardial oxygen consumption and eventually decrease the cardiac output. Adrenaline. Adrenaline again is an endogenous catecholamine, has stronger beta adrenergic 1 and 2 more than alpha adrenergic receptor activity. At lower doses, 0.02 to 0.1 microgram per kg per minute, it increases the cardiac contractility, heart rate with modest vasodilatation. At this dose, it also increases cerebral blood flow by increasing the systemic blood pressure. At high doses of more than 0.5 microgram per kg per minute, it causes excessive vasoconstriction, increased metabolism, hyperglycemia, and increased lactate levels. Side effects include arrhythmias, splanchnic vasoconstriction, which is more compared to NORAD and dopamine. Preterm infants who receive very high dose of adrenaline, more than 1 microgram per kg per minute, have a high risk of mortality. Noradrenaline. Noradrenaline has a predominant vascular and myocardial alpha 1, mild to moderate myocardial beta 1, and minimum beta 2 actions. Its principal cardiovascular effects is peripheral vasoconstriction combined with moderate positive inotropy. In addition, noradrenaline has a vasodilatory effect in the pulmonary vascular bed in neonates and with high basal pulmonary vascular tone. Dose ranges from 0.02 to 0.4 microgram per kg per minute. And higher doses can cause excessive tachycardia and can potentially increase myocardial oxygen demand and worsen the ventricular function. Side effects include hypertension, peripheral vasoconstriction leading to ischemia and arrhythmias, although it is less pro-arrhythmogenic compared to adrenaline and dopamine. Coming to milrinone. So milrinone is the only drug which doesn't act via all these receptors. It acts via inhibition of phosphodiesterase type 3, and which increases the cyclic AMP and calcium concentrations in the cardiac and vascular smooth muscle cells. It improves systolic and diastolic ventricular function through positive inotropy and lusotropic effects on the myocardium. It has vasodilatory effect in the systemic and pulmonary vascular bed. It is used in units predominantly for pulmonary hypertension and low cardiac output, both before and after cardiac surgery, but it can be also used in preterm neonates at risk for low systemic blood flow. Half-life of milidron is approximately 4 hours, and the clearance depends on the renal function and gestational age. The loading dose is not required in units, but when we are using it, we should be aware that once you start the drug, it may take 1 to 2 hours before you see any changes in the blood pressure. Dosing range is from 0.25 to 0.75 microgram per kg per minute, and doses more than 0.5 microgram per kg per minute can actually lead to hypotension. Common side effects are thrombocytopenia, hypotension, tachycardia, and in preterm neonates where the kidney clearance is not good, it can actually accumulate in the system. Vasopressin. It's a potent endogenous vasoconstrictor. The vascular effects are mediated through the V1 and V2 receptors in the blood vessels. At low dose, it causes selective vasodilatation in pulmonary, coronary, and cerebral vasculature and vasoconstriction in other vascular beds, resulting in increased mean blood pressure and decreased pulmonary to systemic pressure ratio in infants with pulmonary hypertension. In neonates, vasopressin has been predominantly used for fluid and catecholamine-resistant shock, and in infants with hypotension and concurrent pulmonary hypertension. Side effects of vasopressin includes hyponatremia, transient thrombocytopenia, and hepatic necrosis. And dose range, if you can see, 0.002 to 0.005 units per kg per minute. There are these 2 points important to consider. The prolonged administration, more than 48 to 72 hours, may actually result in suppression of endogenous production of vasopressin. And once you wean the drug, it can cause lots of fluid imbalance. And in severe cases of PPHN, where using both vasopressin and inhaled nitric oxide, you cannot wean both them simultaneously. If the arterial pressure is adequate and patient is still more than 50%, you will wean the vasopressin first. And in cases where arterial pressure is borderline and FiO2 has come to less than 50%, then you can wean the nitric oxide first. This is just the figures showing what we have discussed till now. If you see on your right hand side, we can see how the drugs are placed. So dopamine, if you can see, has some positive inotropy effect at low doses and minimum vasoconstriction effect. But at higher dose, dopamine has much higher vasoconstriction at but similar inotropy effect. Dobutamine, if you can see, has some vasodilation effect and inotropy. And adrenaline at low dose again has some inotropy and vasoconstriction, but at higher dose, it has much more vasoconstriction and some more inotropy. Norepinephrine has much more vasoconstriction than inotropy, and vasopressin is a pure vasoconstrictor. So now we know a little bit about vasoactive drugs, so we can see how we can use this vasoactive drugs in the common scenarios, what we see in day-to-day practice. And in the second part of the talk, we'll also see how point-of-care echo can help us choosing what vasoactive drugs can be used. So what I have done here is, once we go through the system, we'll also see if NNFI has any guidelines, what we can use for these situations. So first is transitional circulatory compromise. So here what is happening, especially in preterm neonates, that after the cord is clamped, there is a sudden fall in preload with rapid rise in afterload, and there is an immature myocardium, which leads to low or normal mean blood pressure, low systolic blood pressure because of poor contractility, low cardiac output, and poor perfusion. So here dopamine is found to be more effective than dobutamine in increasing the blood pressure. Adrenaline is found to be as efficacious as dopamine in normalizing the systolic blood pressure and improving the cerebral perfusion in preterm infants, albeit with more tachycardia and higher blood lactate levels if given at high doses. In small randomized control trial, vasopressin produced a comparable increase in blood pressure in extremely low birth weight infants without producing tachycardia. So NNFI guidelines of 2023 also says that among preterm neonates with transitional shock, adrenaline can be used as the first line drug of choice with fluid refractory shock. It can be started at 0.05 microgram per kg per minute and incremented by 0.05 microgram per kg per minute every 30 minutes till a maximum dose of 0.3 microgram per kg per minute. It is not applicable in newborns with known hypovolemia, hemorrhagic or septic etiology of shock. In patent ductus arteriosus, a large or a hemodynamically significant duct is associated with reduced left ventricular afterload, increased preload, and high stroke volume. A hemodynamically significant duct, unresponsive to pharmacological closure, is challenging as the left ventricular systolic function is not compromised until late. An administration of inotropes without significant vasopressor effect, such as dopamine and milrinone, will not increase the BP in such situations. Dopamine is preferable for management of hypotension associated with a large duct because of its non-selective vasopressor effect on both systemic and pulmonary vasculature. And selective peripheral vasopressor inotropes, such as noradrenaline, can lead to decreased systemic blood flow by further increasing left to right shunting. And in this newborns who have gone through post-PDA ligation, there is already LV systolic dysfunction, and after ligation, there is suddenly high afterload, low preload, which can lead to sudden deterioration causing hypoxia and low blood pressure. And in this, the inotropic agent of choice, if there is associated low diastolic blood pressure, is glutamine, and if there is normal or high diastolic blood pressure, it's milrinone. So NNFI says that among neonates with cardiogenic shock due to PDA, dopamine is the first line inotrope. Dopamine may be initiated at a dose of 5 microgram per kg per minute, and if needed, incremented by 2 microgram per kg per minute every 20 minutes until a maximum dose of 10 microgram per kg per minute. There is insufficient evidence to recommend for or against other inotropic agents or vasopressors as the first line drug. Inflammatory conditions like neonatal sepsis or NEC can produce generalized vasodilatation and capillary leak and intravascular volume depletion and hypotension. In early phase, there is increased heart rate, stroke volume, and systemic blood flow, leading to warm shock. And in late phase, there is myocardial dysfunction, reduced stroke volume, and excessive vasoconstriction, leading to cold shock. And there can be pulmonary hypertension present at that time. In general, predominant vasopressors are preferred for management of warm shock, and inotropes with additional vasodilator action for cold shock. So dopamine and adrenaline has comparable efficacy in increasing blood pressure, maintaining hemodynamic stability, and improving metabolic acidosis in septic neonates with warm shock. Noradrenaline may be preferable in neonates with septic shock who have pulmonary hypertension because of its favorable effect on the ratio of pulmonary to systemic vascular resistance. And vasopressin can also be useful in septic neonates with refractory shock and high pulmonary vascular resistance. So NNFI says that dopamine or epinephrine may be used as a first-line vasoactive agent in neonates with septic shock. Dopamine may be initiated as a dose of 10 microgram per kg per minute, and if needed, incremented until a maximum dose of 20 microgram per kg per minute. Epinephrine may be initiated at a dose of 0.05 microgram per kg per minute, and if needed, incremented every 20 minutes until a maximum dose of 0.4 microgram per kg per minute. In neonates with perinatal asphyxia, the common hemodynamic disturbance include ventricular dysfunction, peripheral vasoconstriction, and pulmonary hypertension. Less frequently, asphyxiated neonates present with excessive peripheral vasodilatation and capillary leak syndrome. Both dopamine and dobutamine improves cardiac performance and systolic blood pressure in asphyxiated neonates, but do not reduce mortality or neurodevelopment impairment. In asphyxiated units who have persistent pulmonary hypertension, milrinone improves global cardiac function and reduces pulmonary vascular resistance and oxygen requirement. And in these babies who require therapeutic cooling, which can cause sinus bradycardia, increase in vascular resistance, and reduction in cardiac output. But there is limited evidence at present to recommend change in the choice and dose of medications during therapeutic cooling. So National Nephrology Forum of India in their 2023 guidelines says that there is insufficient evidence to recommend a specific vasopressor or inotropic agent as the first-line drug in neonates with cardiogenic shock secondary to birth asphyxia. Clinician may choose to start dopamine, dobutamine, or epinephrine. Pulmonary hypertension. So Dr. Parneet has already covered most of the pathophysiology, what we are going to see. Mostly, it is seen with transitional circulatory maladaptation, neonatal sepsis, congenital heart disease, and pulmonary parenchymal diseases. What is happening here is high pulmonary pressures lead to reduced pulmonary blood flow, systemic venous return, and there is ventilation perfusion mismatch, hypoxia, and right ventricular dysfunction over time. Low ventricular preload, compensatory tachycardia, and leftward septal dilation can reduce the left ventricular filling, compliance, and systolic performance. In PPHN with right ventricular dysfunction, milrinone improves cardiac function and reduces pulmonary vascular resistance and oxygen requirement. Noradrenaline can be helpful when pulmonary hypertension is associated with low systemic vascular resistance and cardiac output as a primary or add-on inotrope. In refractory pulmonary hypertension, vasopressin improves oxygenation, blood pressure, and renal perfusion, and reduce nitric oxide requirement. These are two slides which I've taken from Cloharty, which guides us in using specific vasoactive drug depending on the point of care echo. Here we are looking at systolic blood pressure, diastolic blood pressure, and from echocardiography we are checking systolic function and diastolic function. So in systolic function, if the systolic blood pressure and diastolic blood pressure are normal, which we see generally in transient circulatory compromise, early PD or asphyxia, where systolic function and diastolic function both are normal, you just give fluid bolus and monitor closely. Where the systolic function is normal but there is poor diastolic function, milrinone is the first drug of choice. Alternate drug can be adrenaline. And in where systolic function is poor and diastolic function is normal, low dose adrenaline and dobutamine can be used. And where both systolic and diastolic function are poor, dobutamine or low dose adrenaline can be used. In conditions where systolic blood pressures are low, but the diastolic blood pressures are normal, with normal systolic and diastolic function, the low dose adrenaline or dopamine can be used. Where the systolic function is normal, but there is poor diastolic function, dobutamine or milrinone or adrenaline low to high dose can be used. In conditions with low systolic blood pressure and systolic function which is poor, low dose adrenaline, dobutamine can be used if diastolic blood pressure is more than 50th centile. And in with diastolic function which is poor, milrinone will be the first drug of choice. In conditions where systolic blood pressure is normal, but the diastolic blood pressure is low, like in warm shock, in PDA, where we are using high PEEP, if the 2D echoes suggestive of that systolic and diastolic function both are normal, you can closely monitor the blood pressure. If mean blood pressure remains low, vasopressin at low dose can be used. Where the systolic function is normal, but there is poor diastolic function, combination of dobutamine plus low dose vasopressin can be used. And in systolic function is poor and diastolic function is normal, dopamine can be used as a first line agent. In systolic blood pressure, where systolic blood pressure is normal, as both systolic and diastolic are normal, like in sepsis or in severe pulmonary arterial hypertension, with normal systolic and diastolic function, low dose vasopressin will be the first drug of choice, and second will be dopamine. With systolic function normal, poor diastolic function, milrinone at low dose or low dose vasopressin can be used. And systolic function and diastolic function both are poor, you can use low dose adrenaline plus low dose noradrenaline. These are my references. Thank you.